Now we are going to discuss another important topic, which is edema. The Greek word edema means swelling. Edema is defined as abnormal and excessive accumulation of free fluid in the interstitial tissue spaces and serous cavities. This is due to disturbances of cardiovascular, renal, or hepatic function, which are often marked by collection of fluid in tissues or body cavities. When the collection is in the tissues, we generally use the term edema, but when it is in the body cavity, we use the word effusions. Edema may be localized or generalized, like generalized anasarca, or there can be ascites, hydrothorax, or pericardial effusion when it is localized. Now, there are certain principles in the formation of interstitial fluid, and that is depending on site of collection. 85% of reabsorbed into the capillaries, 15% returned to the circulation via lymphatics. The collection of fluid in the tissue spaces is regulated according to Stalin's hypothesis, which incorporates following factors: capillary hydrostatic pressure, interstitial tissue pressure, plasma oncocytic pressure, and then there is endothelial permeability and lymphatic function. Now, this is the photograph which shows that at the arterial end, the hydrostatic pressure is 35 millimeter of mercury, whereas colloid osmotic pressure is 25 millimeter of mercury, with the result partial pressure is plus 10 millimeter of mercury. So there is net transudation of fluid, whereas in the middle of the vessel, the hydrostatic pressure and the colloidal osmotic pressure is the same, that is 25 millimeter of mercury. With the result, there is no movement of fluid. On the other hand, at the venous end, the hydrostatic pressure is 15 millimeter of mercury and colloid osmotic pressure is 25 millimeter of mercury, which means that colloid osmotic pressure is higher than the hydrostatic pressure. With the result, there is net reabsorption of fluid. So either increased capillary pressure or diminished colloid osmotic pressure can result in increased interstitial fluid. Imbalance between the production of interstitial fluid and return to blood by reabsorption and by lymphatics results in edema. Now, the same pathogenesis of edema is elaborated here. The red lines show arterial side of the vessel where hydrostatic pressure is 35 millimeter of mercury and colloid osmotic pressure is 25 millimeter of mercury, and the arrow points that the fluid is going out of the vessel. Now, at the venous end, which is marked with blue lines, you can well appreciate that colloid osmotic pressure is 25 millimeter of mercury, whereas hydrostatic pressure is about 12 millimeter of mercury. With the result, the fluid is reabsorbed at this end. Now, you can well imagine that there is tissue tension, 3 to 4 millimeter of mercury, which also holds the fluid, and the fluid is then drained by the lymphatics. The arterial hydrostatic pressure tends to cause transudation of salt and water out of the capillaries. The oncocytic pressure of plasma proteins tend to draw fluid back into the circulation. There is overall loss of fluid from the capillary at its arterial end and reabsorption at its venous end. About 15% of fluid accumulating in the interstitial space, they pass into the lymphatic vessels. From here, it passes into the general circulation via the main lymphatic channel. So the other definition is an abnormal increase in interstitial fluid within the tissues is called edema, while fluid collection in the different body cavities are variously designated as hydrothorax, hydropericardium, and hydroperitoneum, also called ascites. Anasarca is a severe and generalized edema with widespread involvement of subcutaneous tissue swelling. Now, here is a flow chart of edema showing that localized edema may be inflammatory due to lymphatics or maybe due to toxic or allergic reaction, generalized edema due to renal, cardiac and nutritional factors, and there is special type of edema which is pulmonary and cerebral. Causes of generalized edema: edema due to cardiac failure, nephritic edema, nephrotic edema caused by liver failure, nutritional edema, that is inadequate intake of proper nutrition, protein loss through gastrointestinal tract also causes edema, edema due to endocrine pathologies, and edema due to pregnancy. Local edema may be traumatic or inflammatory edema, obstruction of venous circulation that can be due to thrombophlebitis or compression of veins, then lymphatic edema and angioneurotic edema. Now you can well appreciate in this photograph localized edema of the leg and of the arm. We also divide edema depending on the nature of the fluid. Inflammatory edema due to increased vascular permeability, and non-inflammatory edema due to osmotic or hydrostatic pressure imbalance. Now, this is the photograph which is taken from Robbins, show that the arterial end, the fluid is going out, shown by green arrow, whereas at the venous end, colloid osmotic pressure is responsible for reabsorption of that fluid. In transudate, increased hydrostatic pressure due to venous outflow obstruction, for example, congestive cardiac failure, fluid leaks from the blood vessel, whereas there is decreased colloid osmotic pressure, decreased protein synthesis in liver disease, increased protein loss through the kidney. They also result in fluid leakage and leads to transudate. In exudate, there is leakage of fluid and protein as a result of inflammation. This may be due to increased interendothelial spaces and vasodilatation and stasis. Now, this is another photograph. The first photograph shows the normal where fluid is coming out at the arterial end and going back at the venous end. The fluid which is left behind is drained by the lymphatics. So pathogenesis here shown: hydrostatic blood pressure forces water out of capillaries at the arterial end, but the plasma oncotic pressure attributed to albumin sucks water back into capillary beds at the venous end, and a small amount of water drains from the tissue through the lymphatic channels. Now, inflammatory edema, as shown in figure B, gaps between the endothelial cells, mostly at venular level, allow water and albumin and other plasma constituents to escape. There is increased lymphatic drainage, but this lymphatic drainage cannot cope with all the water released into the tissues, and edema results. Venous edema, increased venous pressure from heart failure, venous obstruction due to thrombus, causes passive dilatation and congestion of capillary bed. With the result, there is increased venous pressure which exceeds that of plasma oncocytic pressure, and so water remains in the tissues. Lymphatic edema, lymphatic obstruction by tumor deposit, filarial parasite, prevents the drainage of water from tissues. Then edema due to hypoalbuminemia. Low plasma albumin concentration reduces plasma oncocytic pressure so that water cannot be sucked back into the capillary bed at the venous end. In case of edema in the subcutaneous tissue, pressure of finger for a short period of time produces a depression known as pitting edema. The other variety is non-pitting or solid edema, in which no pitting is produced on pressure, and that is seen in myxedema and elephantiasis. The edema may be of two main types: localized when limited to an organ or limb, for example, lymphatic edema, inflammatory edema, allergic edema; generalized edema or anasarca or dropsy when it is systemic in distribution, particularly noticeable in the subcutaneous tissues, for example, renal edema, cardiac edema, nutritional edema. Besides this, there are a few special forms of edema like pulmonary edema, cerebral edema, which we are going to discuss in the later part of the discussion. Depending upon fluid composition, edema may be transudate or exudate. Transudate, which is more often the case as in the edema of cardiac and renal disease, whereas exudate is an inflammatory edema. Now, an important examination question: differences between transudate and exudate. Transudate, non-inflammatory, low protein content, fibrogen is absent, no cellular debris, specific gravity less than 10-12, and the cause is imbalance between the hydrostatic and colloid osmotic pressure. Exudate, it is inflammatory in nature, it has high protein content, fibrinogen is present, cellular debris is present, specific gravity is more than 10-12, and this is because of increased vascular permeability. Causes of edema: increased hydrostatic pressure, that is outflow increased, impaired venous return, there is heart failure, right heart failure resulting in systemic edema, whereas left heart failure resulting in pulmonary edema, constrictive pericarditis resulting in systemic edema, cirrhosis of liver leads to ascites, obstruction or narrowing of the blood vessel leads to local edema, and this obstruction may be due to thrombosis, external pressure, inactivity of limbs, then arteriolar dilatation, which is seen in heat, and neurohumoral activation. Then the other cause of edema is decreased colloid osmotic pressure of plasma, and that is reabsorption is decreased. The critical level of plasma protein is 2.5 gram per deciliter, and this is due to decreased intake, which is seen in malnutrition, decreased synthesis of protein, which is seen in cirrhosis of liver, and increased loss of protein, which is seen in glomerulopathies and gastroenteropathies. Then sodium retention, which leads to increased hydrostatic pressure and decreased vascular colloid osmotic pressure. And this is due to increased salt intake with renal impairment, increased tubular reabsorption of sodium, decreased renal perfusion, increased renin-angiotensin aldosterone secretion, lymphatic obstruction, may be inflammatory, may be neoplastic, may be post-surgical or after irradiation. Then other causes are increased capillary permeability, which is seen in inflammations, burns, allergy, trauma, angiogenesis. Then abnormal development of lymphatics, which may be simple, or there is a disease which is known as Mallory's disease. It is a familial disease characterized by lymphedema, commonly in the legs, caused by congenital abnormalities in the lymphatic system. Disruption of the normal drainage of lymph leads to fluid accumulation and hypertrophy of soft tissues. Types of edema: local edema, which includes acute inflammatory edema, hypersensitivity edema, edema in venous obstruction, lymphatic edema, as seen in filariasis, carcinoma, breast, hemiplegia, and primary lymphedema. Generalized edema, cardiac edema due to right heart failure or constrictive pericarditis, renal edema, which is acute glomerulonephritis or chronic glomerulonephritis, nephrotic syndrome, nutritional edema, pregnancy may lead to edema, hepatic causes, and protein losing enteropathy. Pulmonary edema, hemodynamic causes, microvascular injury, or edema of undetermined origin. Now we will briefly discuss pathophysiology of various types of generalized edema. Heart failure, that is left heart failure, decreased cardiac output, accumulation of fluid in left ventricle, congestion of blood in left atrium, congestion of blood in pulmonary veins, increased capillary hydrostatic pressure resulting in pulmonary edema, which is seen in heart failure. Right heart failure, there is decreased contraction of right ventricle, congestion of right atrium, congestion of superior and inferior vena cava, and increased congestion in venules and capillaries, resulting in generalized edema. Nephrotic syndrome leads to heavy proteinuria, leading to hypoalbuminuria, leading to decreased plasma oncocytic pressure and generalized edema. Now this chart shows nephrotic edema and nephritic edema. Cause: nephrotic syndrome. In nephrotic edema, glomerulonephritis, either acute or rapidly progressive in nephritic edema, proteinuria heavy, proteinuria moderate, mechanism decreased plasma oncocytic pressure, sodium and water retention in nephrotic edema, whereas sodium and water retention is there in case of nephritic edema. Degree of edema, severe and generalized, whereas in nephritic edema it is mild. Distribution, subcutaneous tissue as well as visceral organs. In nephritic edema, loose tissue, mainly face, eyes, ankles. Edema in liver cirrhosis, whether there is nodule or fibrosis, leading to sinusoidal hypertension, which leads to portal hypertension, resulting in ascites. On the other hand, in liver cirrhosis, there is decreased plasma protein synthesis, decreased oncocytic pressure, and generalized edema. Nutritional edema is seen in malabsorption syndromes, Kwashiorkor's disease, gastrectomies, and cancer. Endocrine and metabolic causes: hypothyroidism, that is myxedema, primarily due to increase in hyaluronic acid, and increased viscosity prevents spitting edema. Graves' disease, Cushing's syndrome, diabetic nephropathy. Now, another flow chart for edema, which is taken from Robbins. There is heart failure leading to increased capillary hydrostatic pressure, marked with green arrow, leading to edema. And then heart failure also leads to decreased renal blood flow, marked with red arrow. This leads to activation of the renin-angiotensin system, which results in the retention of sodium and water, and this causes increased blood volume and edema. Now, renal failure also leads to retention of sodium and water, leading to increased blood volume, resulting in edema. Now, on the other side, there is malnutrition, hepatic synthesis, nephrotic syndrome, decrease plasma albumin, marked with red arrow, leading to decreased plasma osmotic pressure, resulting in edema. Pulmonary edema causes and classification: hemodynamic causes, which is due to increased hydrostatic pressure due to left heart failure, mitral stenosis, pulmonary vein obstruction. Then decreased colloid osmotic pressure due to hypoalbuminemia, nephrotic syndrome, liver disease, protein-losing enteropathy, and then lymphatic obstruction. The other causes are microvascular injury, which is the result of infections, gas inhalation, liquid aspiration, drugs, inhalation of certain chemical agents, and radiations. Edema of undetermined origin, which is seen at high altitude and neurogenic. Now, pathogenesis: acute damage occurs in alveolar capillary walls and epithelial cells. Alveolar macrophages and other cells release cytokines. These cytokines are chemotactic to neutrophils. Neutrophils must migrate into the alveoli through pulmonary capillaries. Capillary damage causes leakage of a protein-rich exudate producing hyaline membranes. Neutrophils damage type 1 and type 2 pneumocytes. There is decrease in surfactants, which causes atelectasis with intrapulmonary shunting. Late findings: repair by type 2 pneumocytes, and then progressive interstitial fibrosis, which is restrictive lung disease. Now, morphology of edema depends upon severity, rapidity, and cause. Morphology of edema: in viscera, gross features: there is enlargement of the viscera, they are pale, heavier, and their capsule is dense. Cut section shows glistening appearance. On microscopy, they are granular, acidophilic, and there is presence of interstitial precipitate. In pulmonary edema, the lungs are often 2 to 3 times their normal weight, and sectioning reveal frothy, blood-tinged fluid, a mixture of air, edema, and presence of red cells. Morphological features: the fluid accumulates more in the basal regions of the lungs. The thickened interlobular septa, along with their dilated lymphatics, may be seen in chest X-rays as linear lines perpendicular to the pleura and are known as Curley's line. Grossly, the lungs in pulmonary edema are heavy, moist, and subcrepitant. Cut surface shows exudates composed of frothy fluid, which is mixture of air and fluid. Microscopically, the alveolar capillaries are congested. Initially, the excess fluid collects in the interstitial lung spaces, which is interstitial edema. Then the fluid fills the alveolar spaces, called alveolar edema, and edema fluid in the interstitium as well as the alveolar spaces appear as eosinophilic, granular, and pink proteinaceous material, often admixed with RBCs and macrophages. This may be seen as brightly eosinophilic pink lines along the alveolar margin called hyaline membrane. Long-standing pulmonary edema is prone to get infected by bacteria, producing hypostatic pneumonia, which may be fatal. Brain edema can be localized or generalized depending on the nature and extent of pathological process or injury. With generalized edema, the brain is swollen with narrowed sulci, distended gyri, show evidence of compression against the unyielding skull. Cerebral edema or swelling of brain is the most threatening example of edema. The mechanism of fluid exchange in the blood differs from elsewhere in the body, since there are no draining lymphatics in the brain, but instead the function of fluid electrolyte exchange is performed by the blood-brain barrier located at the endothelial cells of the capillaries. Cerebral edema may be of three types. Vasogenic edema, this is the most common type and responds to edema elsewhere, resulting from increased filtration pressure or increased capillary permeability. Vasogenic edema is prominent around cerebral contusions, infarcts, brain abscess, and tumors. Grossly, the white matter is swollen, soft, with flattened gyri and narrowed sulci. Sectioned surface is soft and gelatinous. Microscopically, there is separation of tissue elements by the edema fluid and swelling of astrocytes. The perivascular, that is Virchow-Robin space, is widened and clear halos are seen around the blood vessels. Cytotoxic edema, in this type, the blood-brain barrier is intact and the fluid accumulation is intracellular. The underlying mechanism is disturbance in the cellular osmoregulation, as occurs in some metabolic derangements, acute hypoxia, and with some toxic chemicals. Microscopically, the cells are swollen and vacuolated. In some situations, both vasogenic as well as cytotoxic cerebral edema results, for example, in purulent meningitis. Interstitial edema. This type of cerebral edema occurs when the excessive fluid crosses the ependymal lining of the ventricles and accumulates in the periventricular white matter. This mechanism is responsible for edema in non-communicating hydrocephalus. Now, dear students, I have discussed the subject of edema, in particularly the morphology of edema in lungs and brain, which I have discussed in detail. However, if you find any difficulty or you have any question, please write in the comment box and inshallah I'll answer it.